Hey, Fix listeners. I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So, if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast.
Oh, sweet. So, this is the only picture on this case, but this was probably the most, if somebody was to ask me, what's kind of been, one of your more surprising cases, it would have to be this one for sure. So this was like an 85, I don't know, maybe she was 78, I don't know, somewhere between that 78, 85 range. I did this case about 3 years ago. Postmenopausal female. She had teeth, right? She didn't have a denture. And so, generally when our patients have teeth, their bone is actually, fairly well. Like I think we have a 95% chance of, utilizing standard implants on patients like that.
Sure.
But, so took out her failing teeth, prepped the alveo, and then just, you hear that, just, that butter bone all the way.
Yeah. She's evaporating. Yeah.
Totally evaporates. And, again, I do surgery the same way on every patient every time. And the key concepts that I teach at my course. And one of the key concepts is bicortical stabilization. Mm. And, once we do our alveolectomy, we kind of remove one of the cortices.
You bet. Yeah.
So then our only cortex here is that, kind of lateral nasal wall that we want to engage our posterior implants with. So, did like a 4.0, 18, I think we got, 5 Newtons, and her nasal cortex was so thin.
Yeah.
I thought, okay, all right, well, let's go from a 4.0 by 18. Let's throw in a 5.0 18. Still absolutely nothing.
Yeah.
So I was like, all right, okay, well, let's go ahead and move on. So then we went to the anterior, and really kind of same thing. I went to the nasal crest, went, medially there, nothing. Okay, no big deal. We'll go lateral nasal, absolutely nothing. So then I'm like, okay, all right, well, that side's a quad, and so let's go ahead and let's go to the left side and see what we get. And posterior left, like 70 Newtons. Like I was like, man, okay, thank goodness I got the posterior tilted on the left.
Yeah.
And so then proceed to do the anterior left side maxilla. Nothing. Right. So I'm just like, oh man, okay, all right. So then I'm like, okay, well, can we at least get the pterygoids? Right. So then, boom, nailed pterygoids bilaterally. So I was like, high fives there. So that, but this patient just out of the blue required a maxillary quad almost, so
yeah. Okay.
Definitely took a lot of time. And but again, my goal here is not to hope. I do not want to then just bury some implants, leave the patient in a denture, for 5 or 6 months, and then come back and uncover and hope that, you have, stability with your implants. So, generally my protocol is, I don't hope. I want to know. Then that's what I teach. And that's why I get these people to, take these advanced courses, so that when a standard case comes up and it's just absolutely butter bone on a postmenopausal female, well, we're still able to provide her permanent fixed teeth in a day, and 2 weeks later she's eating a hamburger,
Yeah.
And you can tell even on her lower, her bone was so soft.
I was just about to say, you get done with this upper and you're like, oh, well, surely the lower will be better.
Yeah. And definitely it wasn't. I mean, we had to use, I think those are 25s and 22s.
Yeah, definitely. Yeah, you're in the inferior cortical border on all 4 of those front 4 implants. And you actually crisscross your anterior ones. I don't see that very often.
Yeah.
Is that what I'm saying? Yeah. Yeah. That's
so, this brings up a really good point. The question sometimes on a mandible is like, okay, well, what width of an implant are you going to use? Like if you're going to use Neodent, which is what I like to use, that you have several options. You have a 4.0 and you have a 4.3, right?
Yeah.
So on a case where, you have to pay attention to your drill, right? If you already know that with your 2.0 drill or your spade, it is super soft, and you're to 18 and you really haven't reached that inferior border, that's okay. But don't place a 4.3 implant, because the challenge that you have if you place a 4.3 and then now you need to switch back and you need to place a GM long.
Yeah, 4.0.
Well, now you have
whatever,
you have 16 millimeters of your osteotomy that's actually 0.3 millimeters wider than your implant. So on a case where you may not want to just throw in a GM long, but you may want to let me try a 4.018. Don't try a 4.318.
I like this. Yeah.
So you try a 4.018, and then if you need to use your 25, well then boom, just bust out your GM long drill, drill to 22, 25, and then now you can put your 4.0 by 25 in there.
Yeah. Yeah, no, that's brilliant. We just did an episode with Cliff Gratz, who's the product development specialist at Neodent, and he was talking about how a lot of where Neodent derives its stability, at least with the GM Helix, is the threads in the crestal portion are compressive. And so if you're not able to engage that with your now GM long implant that is undersized for your osteotomy, you're not getting any of that compression. And now you're just relying on stability from that cortical engagement, which, it'll work. You'll get some torque, but not as much stability of the implant as you would had you not oversized that osteotomy.
Correct. Yeah. So then if you roll with your 4.3 and then downsize to a GM long 4.0, then you're right. You're just getting that apical stability, which works. I mean, I have never had a GM long implant fail, and I've used quite a few. Just because we get really good stability down here, it winds up being the same principles as zygomatic, right?
Yeah.
Just because you have just that such a long implant. But I also, every case I do, we provided that they can do it, we do 6 implants in the mandible. And so, I prefer to load, and I have not seen crestal bone loss with, loading the posterior implants.
Yeah.
So, that really helps with just getting everything very, very fixed.
Yeah. But are you usually using those GM shorts, or do you use a lot of the 8 millimeters, the regular GM?
Yeah. I mean, I think my preference, it always just depends. I go back and forth. I like the 507, right, which is a Titamax.
Yeah.
And I like that because you don't have to buy a different abutment. The GM abutments or the GM short abutments are different. And it's a more parallel, right? A more parallel implant actually gives you more compression than a tapered implant. And so, that's so Paulo Malo, what he created was the Nobel Speedy Groovy. And he was like, we get more compression with the Nobel Speedy Groovy than you do with the Nobel Active, because the Nobel Active was tapered. And so, that's where the GM Helix really is a great implant, because it's apically tapered, but then in the mid body and the coronal portion, it is a parallel.
Yeah.
So it's super compressive, which is really great.
Awesome. Yeah, I use a lot of 4.3x8s and 5.0x8s and the
Yeah.
GMs, but
Yeah.
it's
Typically in
Titamax is nice. It's a good idea.
typically in the posterior, it's all 5.0s.
Yeah.
And I've used a lot of the GM shorts, 5.0 by 5.5, and then really that 5.07 is really fantastic.
Yeah, that's nice. I might need to try that. It's going to give me a little bit more flexibility. That's really nice.
But I would, if I'm leaning to a 5.0 GM short 7, I would rather just use a 5.07 Titamax and be able to keep the same abutment.
Yeah.
Yeah.
That's kind of what's kept me away from using the shorts is I don't want to use different buffets.
No, but I mean, I've had so many patients where, literally the nerve is at 6 millimeters, 7 millimeters, from the crest. And so that 5.0 by 5.5 works really well.
And if you're not going to do any alveo, you can still grab that bicortical. Well, not bicortical, but you still have the cortex to give you stability, which you get a little more success that way. So yeah, very nice. Here we go. This is great.
Yep. So here we have one of my cases for sure, and patient came back and he was like, "Oh, I'm speaking kind of nasally," and I'm like, "Okay," and he's like, "I'm getting some fluid in," but he's like, "Not all the time. It's kind of rare." So I was like, "Hey, buddy, let's just take your prosthesis off and let's look under the hood." And lo and behold, boom, there's this nice little hole staring back at me. And I'm like, all right, well, we're gonna fix that. So again, fixing an OAC, my preference is, can I close it with a pedicalized CT graft?
Yeah.
So let's hit the next slide. I think this particular patient, we were not able to close the hole. Yeah. So oftentimes, I run a busy clinic. I'd love to, just be able to take photos all day long. I can't.
I get it.
But I didn't take a picture of the hole. I think in the chat, I've sent several holes that have been like the size of your thumb,
Yeah.
And it's like there's not enough connective tissue in the world that will close that.
Of course.
But so my protocol is, okay, we're going to rotate the pallet, rotate the connective tissue graft over. Let me see if that will close it. If it won't, then that's when we have, okay, now we're going to need to advance the buccal fat pad to close it. And here, we're able to advance the buccal fat, and look how nice that capsule.
Beautiful. Yeah.
It's not stringy. It's not pulled. That's what you want your buccal fat pads to look like. If your buccal fat pads are stringy, they're just going to die.
Yeah.
But so we pull this forward, and my preference here is that we wind up with a multi-layer closure. Okay, so we'll have buccal fat, and then this picture to the right is actually the pedicalized CT graft. And so that is going to go over. We're then going to create a transosseous suture so that we can then suture all of that down and make it very stable. Sometimes I'll secure. Sometimes I will secure the buccal fat into the vestibule as well. But I if you can, I prefer to get it down to the maxillary alveolus. So buccal fat, connective tissue, and then we'll close it with our mucosa. So we get a really nice triple layer closure there.
Very nice. So the buccal fat, the CT, and just mucosa closing over the top of it. That's our tri-layer. Very nice.
Yep.
Yeah. Beautiful. Awesome. Yeah, you can see how vascular this tissue is. Beautiful.
And there's your closure.
Yeah.
Sometimes you have to pay attention to your prosthesis because now you've kind of shortened the vestibule.
Yeah.
So you need to relieve your prosthesis a little bit so that you don't wind up cutting into your mucosa
Yeah.
or compressing onto the buccal fat. And also we need to pay attention posteriorly. There are several times where I will then do a minor sinus crush posterior to this area so that I move the maxilla a little more superiorly so that we still have a lot of restorative space, because you got to think we're gonna have connective tissue, we're gonna have buccal fat, all that can wind up taking up some of your restorative space.
Yeah, for sure.
So
And do you recall?
Sometimes we'll tap that down.
Do you recall how long post-operative this was?
Well, this picture here is immediately post-operative surgery.
No. I mean, like, when did he have his initial surgery and when did the OAC present? Is that usually an early complication, late?
It's definitely an early complication. It's within 3 months. Yeah.
So this is another one I stole from Tribe. So this is from Dr. Bruce Smoller. He shared it in the group, so I assume that he'd be all right with us talking about it. And he had Dr. Juan Gonzalez come in to help with the closure. And this is going to be very much like what you already reviewed. But you can see this is a really sizable, OAC we have here on the left. And I don't recall the entire history that Bruce shared, but I think that was a zygote that had to be extracted, and they closed over it, and then it opened back up, and now they're dealing with an OAC. Yeah.
You're taking out the sinus tract and taking out the fistula.
Mm-hmm.
Just here, Juan's getting a really nice distal incision.
Yeah. And so is he reflecting tissue? The point of this is to go in from back to front and reflect all the tissue instead of doing it directly over the defect. Is that what's happening here?
Go to the next slide.
Yeah. It shows the whole incision design a little bit. Yeah.
Yeah. So, they did not, they wanted to be able to rotate that tissue. So he went distal to it so he can actually rotate that tissue more anterior.
Okay. Oh, okay. I understand that. Okay.
And then really nice description here. This is great. I mean, this is a, across the midline, palatal incision.
Yeah. That makes sense.
So just reflecting there.
And there's our wedge.
Yeah. So then that's obviously that was rotated from an anterior position. Yeah. Now rotating that posteriorly and laterally.
Is there a reason why? I mean, do they typically go that way? Like you're incising anterior to posterior and then you're swinging it back versus going the other direction, like back to forward, and then you loop around?
Well, that's a really good question. Where does the blood flow come from?
Well, coming from the GP ultimately, right?
Right, which is in the posterior, right? Yeah, so if you cut it off at the posterior and then rotate it anteriorly, well, now it's just going to necrose and die because you cut it off of its blood supply.
That makes sense. Makes a lot of sense.
Very good question. Yeah, these are always rotated from an anterior to a posterior.
Great.
And then this is just, Juan doing that lasso kind of that we talked about, where you're gonna go through your buccal fat several times to really get a good web. I would call it more of a web than a lasso, but whatever.
Yeah. Well, yeah, he's in Texas. Well, I guess you are too. So
we got a lot of spider webs here, so I call it
sure thing. Yeah, that makes sense too. There we go.
So just, again, just kind of securing that down with a transosseous suture.
And I assume that in trying to cover this defect, ultimately, we want to have quite a bit of BFP, circumferential to the defect. Is there any guidance on like how much more we need to overlap it?
So the buccal fat will contract, and so
Yeah.
that's kind of one of the disadvantages of it.
Okay.
So I would definitely go double the distance that you need.
Okay.
I mean, to me, this is a little risky where, you know, if the tissue's really that they're beginning to do a split tissue thickness to
Yeah.
then uh advance kind of that lateral mucosa and kind of move it medially. The challenge that you can get there is if you overscore it, you can really kind of impede your blood supply kind of on that
Yeah.
lateral aspect of it.
Yeah. That makes sense.
But you need to mobilize the flap. And so, it's really easy to do this when you're doing arch surgery. It's oftentimes a lot more complicated whenever you're fixing a complication from arch surgery, because oftentimes, your flap hasn't been elevated for as long. It's not as
Yeah.
big. So, I always think you do more harm to the patient with a smaller flap. And bigger flaps sound scary to people. They think that, oh my gosh, Mrs. Jones is really going to be pissed if I give her a big flap. Well, she's really going to be pissed if you tear the tissue,
Yeah.
and then you're going to have other sutures here or there that are going to contract. So, that's kind of one of the reasons, if you look at Dan Holtzclaw's remote anchorage book, I don't like doing kind of that first molar kind of lateral incision that he kind of makes.
Yeah.
Because oftentimes that's going to be right over
Yeah.
my zygomatic, and here
Yeah.
we are with an incision running up that whole running superior and lateral right over our zygomatic. So my preference is I just go straight back all the way over, all the way to the plates, and then a nice big lateral pull.
So do you do like a releasing incision at all back there, or is it just going so far distal that you're not going to have as much tension on your flap?
Yeah, I mean it's so far distal. I mean, I guess you could say, there would be a slight vertical releasing incision in that hamular notch.
Okay. Yeah.
But
kind of like a hockey stick sort of.
Some people don't even have a real notch there, so really it's just going straight back.
Yeah. Okay. Yeah. No, I've definitely been adherent to the releasing incision up that process there, but so often I've found myself having split tissue right where a fixture is, and it's just it's not an ideal situation.
Yeah, and you're compromising blood flow.
You bet. Yeah, of course.
So, I know Bruce gave us this. He says, obviously they were going for 3 layers of closure, but then somehow he says they got 4. I don't know where they got the 4th layer from.
That was a question that I had for you. But
yeah. So, again, just it's kind of the same principles. Buccal fat, maybe they're calling that 4th layer, maybe some of the tissue that they advanced over that, but I would still just call that
flap, maybe.
Yeah.
Okay, that makes sense. I'm curious, would there be any use or utility at all in using a membrane at all?
Good question. People ask that kind of stuff all the time. Should I graft? Should we do? Generally in these, the least amount of intervention is best.
Okay. Yeah.
You put something there, and then, the last thing you want is, now all of a sudden you have something in the sinus, and then they get a sinus infection, and then, then you're back to OAC again after you've already, had all this major, type of work. So generally less is more.
Okay, cool. And I'm curious too. So what if, what if you're in this situation and you use the buccal fat pad during the surgery? What do you kind of have to work with?
Well, that's why I don't.
Yeah, don't get in that. Just don't do that. There we go. Fair enough. Okay. So mucosa is the fourth layer, but I still count 3.
I count 3. I think they're being special here, but that's all. That's all.
And I wanted to throw this one in because we kind of alluded to this earlier when it comes to thinning the tissue, and people talk about bleeders and such. We have a really nice video here, and you can see quite a gusher there.
Yeah, I mean, you could imagine just left untreated, even though that's actually a small arterial.
Yeah.
Probably, I mean, if you were to leave that for about a minute, the whole,
Yeah.
I mean, maybe less, the entire mouth would be full of blood.
There
Probably
it is.
actually
It's overflowing.
20 seconds.
Yeah, right there. Yeah.
So, obviously this patient's under general anesthesia, so I know their blood pressure is low.
Mhm.
Their blood pressure there is probably, I bet you they're 100 over 60.
Yeah.
They could be 95 over 60, or 95 over 55. But and I mean, imagine encountering that on an awake patient.
Yeah.
They're going to be freaking out.
No question about it. So is your first go there is just electric cautery? It's gonna be the quickest thing.
Totally, electric cautery, quickest thing. And you turn the power up on the unit, so you just zap it and it's done.
Yeah.
You need to act fairly quickly on these. If you're dealing with a older patient, and if they've already lost a fair amount of blood, which obviously they do in these surgeries, they can have trouble you can have trouble getting them from the chair into the wheelchair. They could pass out.
Yeah. Oh, you bet. Yeah.
So it's always a good idea post-operatively to at least give your patient a good 500 cc bag of just
Fluid.
Sodium chloride, just some fluid, right?
Okay.
Just to kind of help with their homeostasis.
That's a great idea. Yeah, I love that.
So here we are. We just do a nice little zap. Did we do the zap?
I think. Well, it seems like I think you had a tip in there that was going to work on it. I don't think this video had the zap, but it looked like you'd actually already done it a few times. So, do you? What is your recommendation on an electric cautery unit?
I don't know. Just Park Hill makes one.
Yeah.
I don't even know the brand that we use, but I think that starts with an A.
I got an Art E1.
I think that's what we have. What we have. Yep, there you go.
Yeah. You have like $800 like eBay.
I think those work great.
Yeah.
The Bantam Pros, the Bovie, that's a really good unit. And what's nice is you can really customize all of your tips that you can just order from McKesson.
Yeah.
So that's also a really good unit.
Nice. And then on this one, so this is one that I found that someone had been a student of your course, and they sent this over. So patient is looking at an upper all in X, and I see this a lot. You've got this really flared maxilla here. And I think we'll see him kind of rotating her skull here. So we can see, I mean, very intact, lower arch, lots of root canals and implants and things, but still got some mileage. But up top, whole lot of, traumatic inclusion. Your teeth have flared out a whole lot. Some skeletal class 3 going on as well, in addition to that. So, the question is, can I treat this person with a single arch, right? Because am I going to end up with a huge anterior cantilever? Is there some other way to set them up on the occlusion? I mean, this kind of goes back to that case 2 or 3 we were talking about, where we had, some collapsed bite. We opened it up. We got some more class 2 characteristic in there. How would you approach a case like this? I know there's more that goes into evaluation, but this is what.
Well, so this is a perfect case example. So this is all the information that was given.
Right. That's all I
And,
got.
you know, I just said, I can't help you. Like, I need to see a Ceph. I need to see like facial profile, like we need to see a smiling photo. Like we have absolutely nothing to go off of,
Yeah.
other than all they're doing is looking at tooth position and bone, right?
Yeah.
So it's missing really what the whole full arch patient is. Facial profile, are they overclosed? Do we need to open them up? Also it goes into planning. I mean, who allowed this patient to spend all of this money on the lower teeth
Yeah.
with nothing against it,
Right.
Um,
Right.
I
Do
mean,
that approach.
I would be shocked. I would be shocked if you told me, oh, this patient got this work 15 years ago. There's no way those are like zirconia crowns. B, if you've lost all those upper teeth, you're going to lose all those lower teeth in a short period of time.
Yeah.
So, not really having all of the info, it's really hard to see. I think the pearl here is if this is all the info that you give, like I need to see a Ceph, full face. I want to see axial images, where, anytime you want to send something to an advanced doctor, send us the axial, coronal, and sagittal images, and take the video where you scroll all the way back, all the way forward, and then come back. Like I want to see you go forward and back, and maybe even forward and back again, and then let's go to the other one. Let's look in the, axial position. Go all the way, all the way down, all the way up. Let's look in the coronal position. And that then really gives us such a better example. I mean, I will see people who've like, oh, I've planned this case, and all they're doing is showing like the 3D recon of where their implants are. And I'm like, well, I have no idea, how much buccal bone do you have to your implant? Where are you in relation to the nasal crest? Where are you in relation to the lateral nasal wall? So there's really so much, that really kind of goes into advising on a case like this. The possibilities here are endless. I ultimately can't say anything. But I mean, I think that your point is really well taken about like, hey, this may be a case. Let's open them up. Let's see how much restorative space we actually have then, and then kind of go from there. Don't just look in a tunnel and say, okay, I can do crowns, and we can do crowns on your lower teeth, and we'll talk about the upper next. I mean,
Now we got here. Yeah.
whenever I talk to a patient and we have a consultation, it is only at the very end of the conversation do I even really kind of look in the patient's mouth. I'm wanting to find out, what are your goals? What are your treatment goals? How does all this kind of come in? Like we're going to go macro, and we may not even go micro, when you're extracting patients' money out of their wallet, think of the end result, right? And, what one little pearl in talking to patients is, if you want to go to the beach, that's great, but you better be specific in what beach you want to go to, because I can take you to a beach in Alaska, or I can take you to a beach in Cabo. Okay. We went to the beach. We did what you asked for, but your expectations were 100% or 180 degrees different from reality.
Yeah. I like that.
So always something to consider and think about.
Very good. Very good. Let's see if I got any more. I don't think I do. Yeah, I think that's my last one. That's slide 49.
Sweet. All right.
Well, that was fantastic.
I think just these are all just examples of learning that, you can be a part of in other implant groups that are out there. You know me, I'm not trying to push my stuff. There's so many things that are out there, but also we talked about the stuff in Texas Implant Institute, in, our All on X cadaver course, in the zygoma and pterygoid course, and just in our WhatsApp group. So, I would love to help you guys along your journey. Visit texasimplantinstitute.com. I have some videos on there now, and we also have quite a few videos on our YouTube page. So check those out. And I'm me and Tyler and Soren, we're all very approachable, and when you care about the patient, there's always enough to go around, right? And so, it's ultimately caring about the patient, but it's also caring about the doctor and their journey, and not having, just a waiting room full of complications and a waiting room full of problems.
Yeah, you bet. I mean, you said it perfectly well. And, I think that being a part of this community, going to your courses, it just needs to be a foundational part of anyone's full arch journey, in my opinion, because you just put together such a good group of people. And there's a whole lot of very honest discussion about how to approach cases, what to do about a case when it's gone south. And it's nothing personal. There's not any judgment attached to that. But I learned something from that group every single day. And it's encouraged me to go back Texas Implant Institute to do more courses there. And we certainly don't really have any incentive to be singing your praises. It really just has been such a foundational part of our development. And, I just appreciate you coming back on here to keep sharing what you share. I mean, you were an incredibly busy doctor. You're having 30 arch months and things like that. You're teaching courses, you're doing all these other things, being expert witness and all that. And you still take time to go in and, help me make a little PowerPoint with all these different case examples to teach people. And I think that's just a really admirable thing that you do. And I really appreciate you, giving us your time and expertise.
Sweet.
Awesome. Well, this certainly won't be the last anyone sees of Clark Damon on the Fix podcast. He's been a repeated guest and certainly a highly valued one. Hope you guys really appreciated, this series that we put together, with all these, visual aids, with all these cases. I think, this is what we really wanted to do with this podcast. Up to this point, it's kind of been a little bit of a challenge getting some of the media aspect into these podcasts. So we've mostly just been talking about stuff, but I hope you guys appreciate the video content. It's certainly a labor of love to put it all together, but I think this is really helpful. I think it's productive. I certainly learned from it. And, Dr. Damon has been very gracious in giving us his time. So hopefully we'll be back with some more video content for you guys. And, let us know how you like it. Let us know how we can change it, make it a little bit more interactive and make it more educational for you. So you don't have waiting rooms full of complications, just like Dr. Damon said.
Sweet. All right. Well, good luck on everybody's journey.
You got it. Thank you.